Secondly now, this is the second speaker of the morning, and it is my pleasure then to introduce to you Professor Sprick. Is an associate professor at the University of Dusseldorf and deputy medical director and head of the Department of Day Clinics and Ambulance at the St. Alexius and St. Josef Clinic in Nusselt, Germany. He is a trained psychiatrist and an expert psychologist, specializing in psychotherapy and forensic psychiatry. He has been working in brain research for more than 10 years with special interest in brain plasticity, endogenic opiates, tropic factors, reward systems, and memory. From the clinical perspective, his actual research interests include non-visual effects of light, cognitive training of schizophrenic patients, and telemedicine, especially therapeutic delivered psychotherapy. Professor Sprick is a member of several medical and psychological societies. Please welcome Dr. Ulrich Sprick.
Okay. Thank you very much for this warm welcome, and thank you, Professor Kalios. Thank you very much for the invitation to be here. It's an honor for me, and my subject is also intercultural and interdisciplinary, because I'm going to talk about psychotherapy via the internet. I come from a clinic, you heard it, in Neuss, in Germany. We work for about 600,000 inhabitants in the surroundings, and we're a clinic of psychotherapy and psychiatry and psychosomatics. And about 8 years ago, we started to do psychotherapy via the internet. It was the very beginning. And I'm going to talk about psychotherapy via the internet as a novel tool in clinical use, because it's not used in many clinics so far, and I'm going to talk about the history and so on. First question is, how new is psychotherapy via the internet? And my first slide says how it all began. Where did it start? It started in the US. The first psychological online help started in 1986, 30 years ago already. And where did it start? It was at the university in Ithaca, New York, a program called Ask Uncle Ezra. There are other forms of sort of psychotherapy. For instance, in Germany, we have this crisis telephone line. You will have this here as well. And this crisis telephone line used online services since 1995, 20 years, more than 20 years ago. Remember, the iPhone was introduced into the market just 10 years ago. So psychotherapy via the internet is still older. If you have a look, what are people looking for when they look in the internet concerning health? About 65%, 2/3, look for special diseases. About the half looks for nutrition and diets. 40% look for medicine and drugs. And about 12% look for sexual problems. The part of psychiatric or psychological problems is rather big, being about 25%. That's quite a bit. And I took a search via the internet on two different times, 2012 and 2016, just hits for psychological online counseling or hits for internet psychotherapy. And I was astonished to see how huge the number of hits was. At Google, I found 888,000 hits for psychological online counseling and 5 million 500,000 for internet psychotherapy. That was 2012. The first date was 26th of October 2012, which is outlined over there. I should have a pointer somewhere. Yes, so I can point it out. Doesn't work. No, this doesn't work, sorry. But I can point it out over here. It's on the 26th of October. Thank you very much. Thank you. Over there, that's the date. And I did it another date as well, 2016. And instead of 880,000 hits, we got 2,700,000, 3 times more. We heard this in lessons yesterday as well, that the curve is exponential. And I guess if we do this, or if I would do this in 2 years again, it would double at least. So this is shows that it is a rather convenient method. And what is psychotherapy and consultation via the internet today all about? You see a variety of options. First, you can see the internet just as a platform of information. You get lots of informations for different diseases. You have the opportunity of psychological consultation via the internet. You can do that asynchronically by email or synchronically by Skype chats, for instance. You have single chats or group chats. One perfect example for this, how it works, was a report of a colleague of Greenland. I met him at a conference, and he told me with these chats, he used Skype chats, he was able to reduce the number of involuntarily stays at the hospital in Greenland to cut it about a half. It is very, very difficult in Greenland if there are schizophrenic patients. They have the possibility to have weapons, and this is very dangerous. So these people, they live up in the north of Greenland, and they have to go down to Nuuk, which is the capital, by sledges, dog sledges, and in wintertime it's very hard to do this. But with a Skype conference, it is possible that the doctor whom they know, who is in Nuuk, he can take care of patients in the rather north with a general practitioner altogether, and then the patient takes his medicine, and he doesn't have to go down to Nuuk. And this, as I said, cut the involuntary treatment at Newark by half. So this is a good example using Skype, which has a problem with data security. You may also divide psychotherapy via the internet into self-help programs or guided help or therapist-delivered help. There are some offers for groups for inpatients after their dismission. And I will tell you another example of a special option which I found incredibly good. There was a treatment of patients living in Iraq, in Kirkuk, and they were treated by specialists living in Germany, also speaking Arabic language. They were safe in Berlin. They never saw their patients in Kirkuk, Iraq, and these patients suffered from PTSD, post-traumatic stress disorder, a disease what I would never have been thinking about, that you can treat this with internet therapy at the very beginning. But it came out, it worked very well. So people from Berlin were able to treat via the internet people in Kirkuk, Iraq. So next slide is about the effectiveness of psychotherapy via the internet. Does it work? Yes, you can say it works. There are a lot of meta-analysis for this, and the general grade of efficiency is about 0.53, which is rather like face-to-face therapy. This is a very rough measurement, taking it all together, different diseases, different types of therapy, and so on. So I've got some recent data about the effectiveness of internet-based psychotherapy for depression. The rate was pretty much like that, 0.56 in meta-analysis. And if you treat anxiety patients, your grade of effectiveness is even greater. So the grade of effectiveness, Cohen's d, is 0.9 concerning significant ameliorations of symptoms. And very interestingly, PTSD patients, they also can be treated very well. The grade of efficiency of Cohen is 0.95 in different meta-analysis on this. There is a difference whether you treat patients with or without contacts to the therapist. If you do so, you see that patients without a direct contact to a therapist show smaller effectiveness and higher dropout rates. This is especially true for patients with depression. Their activity is rather low. This is a very new comparison, meta-analysis of effectiveness of internet psychotherapy versus face-to-face psychotherapy. This was done by Anderson and co-workers from Sweden. And as you see here, on the left-hand side are the studies who favor internet therapy, and on the right-hand side over here are the studies who favor face-to-face therapy. And if you take them all together, you find that there is no advantage of neither of them. Psychotherapy via the internet like this is as good as face-to-face therapy. This was done with guided internet psychotherapy. It is a little bit different with unguided or self-help. So I want to give you a short example. Yesterday I had some slides about the sort of internet therapy next step, what we do in noise, but these are just examples. These are the co-workers we are working with, university, the AOK, which is a big insurance company, and our key point is that we have therapists delivered internet psychotherapy with a low number of face-to-face contacts. That means we blend this. We have a blended concept, so we see our patients face-to-face and then treat them via the internet. And we use modules of cognitive behavioral therapy. Data security is a big point using the internet. We have security levels of online banking. We have our data stored in fractals on several servers which are in the ITC center of our clinic. We don't put these data into the clouds. However, data via the internet will never be 100% secure. That's for sure. There are some particularities using internet delivered therapy. Communication, we use communication in a written form, and that needs more training for the therapists compared to conventional face-to-face therapy. They learn face-to-face therapy after university, but nobody learns doing psychotherapy in a written form so far. You need specific supervision by psychotherapists who have their own experiences on this method. And we have this relatively high effort and expenses because we use during the diagnostic phase an interview, a personal interview with the psychotherapist plus an interview with a psychiatrist. So we can rule out medical reasons for a psychic disease. We have some exclusion criteria for internet psychotherapy, that is acute suicidality, psychotic thoughts and experiencing, or dissociative experience. The very last one, comorbid drug or alcohol addiction, was just an exclusion criterion in our study. We compared this. These are the modules of NetStep. We have a 7-module document using it from psychoeducation. We have this is typical cognitive behavioral therapy, as you see. If you're acquainted to this, you see it all what you find in normal face-to-face therapy as well. Balance and equated thinking. You think about your aims and values. You have your self-image and self-perception as a subject. The social competence, self-perception, social situation. That means you don't do the therapy just behind the computer. You have to go out to do these treatments and report afterwards to your therapist. And the very last model is about relapse prevention, which is also a very important one. Some data of this show that we have a very high effect, that there's a BDI score, a standard score for depression. If you are higher than 18, you're depressed. And you see after 12 weeks, patients had levels of about 10. And this showing that the psychotherapy via the internet has a very good effect. We also had a waiting group over here. You can see after 12 weeks of waiting, there was nothing happening. And then getting the internet therapy, you have a very good effect. And we compared this also with face-to-face. This is the internet group over here. This is face-to-face group. Both had a very good effect. That you see that also the face-to-face patients who had randomly lower degrees at the very beginning, this was not significant, showed a very good effect. So this is also an example who uses internet therapy, and as we started, we thought that would be a good idea for young males who are very affine to the internet. But it came out that it was primarily people being about 40 years old, the 4th decade, they used it, and it was mainly women who used it, about 64% in our study. In other studies, you find 80 or 90% women who uses it. And the status of education of people using internet therapy is also interesting because they have a higher grade of education. More than half of the patients, 56%, have finished high school. This is not a true image of the normal population. You find this also in other studies. We also looked for social relations of our patients, and so about the half of it was in a fixed partnership. There was, interestingly, no difference in between country or city sites. We also looked for pre-treatments, and we saw that about 60%, nearly 60%, exactly 59% of our patients already had pre-treatments before, several pre-treatments or at least one pre-treatment. So these were not all new patients. And we looked for specific life situations of patients using NetStep. It was our hypothesis that mainly people who use their mobility at work, that they use an internet-based psychotherapy. In some cases, it was the case. For instance, one woman which we treated, she went from Neuss, from Germany, to Dubai to work there. And she could do her therapy via the internet from Dubai. That was no problem. Others did that from other countries in Europe as well. But the part of them was just 10%. There was another part, 71%, which had no specific situation, like having a child or wishing to have psychotherapy on certain hours or so. There was no specific situation in 71%. We asked these patients, why did you do internet psychotherapy? Why didn't you go for face-to-face? And the answer was the waiting time. They had to wait. If they want to wait face-to-face, if they want to do face-to-face therapy, they had to wait for several months normally. And with the internet therapy, we were able to get very direct access to therapy. So that was their reason. And we asked the patients, are you content with therapy? Would you recommend this kind of therapy? And would you reuse it if you would ever need psychotherapy again? And nearly 90% of our patients said, okay, this is a type of therapy I can recommend. And I would recommend it to a friend, and I would reuse it again if I should ever use psychotherapy again. Once again, in different studies, who uses internet psychotherapy? The amount of female users is very high, and the mean age is around 40 years. It was not the young males, as I already said. The other point is, are these therapeutic effects of internet psychotherapy sustainable? Do they last? And there are several studies who can show, yes, they do. Improvements after internet psychotherapy held on for months. It was published by different authors. And the next point is a very interesting point, I think. What about the therapeutic relation in online therapy? Because this was a question of therapists. What do the patients think, and what about all the therapeutic relation, which is very important for psychotherapists doing this? And the question was, would the patients accept it? And who decides whether the therapeutic relation is good or bad? I think let's ask the patient. And there are some studies who did that, therapeutic relation via the internet. And there is an instrument, the Working Alliance Inventory, where you can ask the patient how he thinks, how good is the therapeutic relation. And this is a scale varying from 1 to 7. And using internet psychotherapy, after the 4th session, the average score was 5.8, which was rather high. Up to the 4th session, until 1st, 2nd, 3rd session, the face-to-face therapy seemed to be a little bit better, but then the internet therapy came up. And there is still a slight improvement until the end of therapy. There is no difference in between young patients, medium-aged patients, or even the elder patients. We call them silver surfers. And they also show that think that the therapeutic relationship is very good. In these studies, you have to administer that some of this show a high dropout rate. And so what one could argue that it is the high dropout rate, you only get these patients who think the therapeutic relation is very good at the very end, and the others who don't, they drop off. That's a point to discuss. However, the score of therapeutic relationship by patients is not a consistent outcome factor. So nevertheless, if it's bad or good, the outcome of therapy is independent from this. This was published by Ulrich and co-workers and Sukala and co-workers. So if we compare self-help and therapist-delivered psychotherapy, we have to favor therapist-delivered psychotherapy because you have a lower number of dropouts in therapist-delivered psychotherapy, and you have more positive effects. This was work done by Sprick and co-workers and teacher. Doesn't astonish very much. And there were some studies about the influence of the amount of personal contact. How many contacts do you need? And if you have a therapy without personal contacts, the grade of effectiveness is 0.2. If you have patients having contacts only before therapy, the Cohen's d is 0.44. If you have contacts during therapy, the Cohen's d is 0.58. And if you have contacts with the patient before and during therapy, you have best a Cohen's d of 0.76 grade of effectiveness. So work done by Johansen and Baumeister. One thing is very important for internet psychotherapy. It's the diagnosis. We have to have the right diagnosis, a true diagnosis. Otherwise, it's very difficult to treat. If you have self-help, very often patients make their own diagnosis. This is rather difficult because you don't get the right treatment if you don't have the right diagnosis. Sometimes you have double diagnosis. You have additional diagnosis, for instance, personality disorders, addiction, plus depression. So a simple self-diagnosis or a shortened diagnosis are not sufficient, in my view. This is also very important to say. Internet psychotherapy is an excellent addition to the wide range of treatment methods. However, it is in no ways a replacement of face-to-face therapy. So it will all be together, not a replacement. This is important to say. What about internet psychotherapy in the US? I looked it up coming here to Florida. And internet psychotherapy may be carried out by licensed psychotherapists and will be financed by insurances in some states. Florida does not belong to these states. There are platforms of therapists and patient networks which are covered by some insurances, for instance, the platform Breakthrough or the platform iTherapy. And there are some programs which are sometimes reimbursed by the employees, sometimes from the state, for instance, Sleepio or Bacon Health Options. That's nearly the same situation as we have in Germany too. Some insurances pay for this kind of therapy, some don't. And I will give you a brief glimpse on what, in my view, will happen in the nearer future. What is it all about that you can use psychotherapy via the internet with new developments? For instance, augmented reality. We already heard about that yesterday. What can it do for psychotherapy? For instance, with augmented reality, it is possible to drop relapse rates. For instance, I have found it very astonishing to hear that it is possible to do this. Drug-addicted or alcohol-addicted patients coming from the clinic, they often relapse. And with augmented reality, it is possible to cut these rates nearly by half. There are instruments, for instance, arm wrists, who can measure the grade of alcohol in your blood. And if the patient knows that this measurement goes to the therapist directly, he will be able to take off from the drugs and he won't take them. And there is even a much more simpler method, which I was very astonished to hear. In the States, for instance, you can use a GPS transmitter on the arm wrist, and this GPS transmitter also prevents drug take. How come? They just coordinate this GPS signal with the cards, for instance, of several states. In the US, alcohol is only sold in liquor stores. And these cards, they have a representation of all the liquor stores in the state. For instance, in Nevada, they did it. And by this, the patients gets a recall, when he come near such a liquor store, and in red letters, big red letters, don't do it. Don't do it. And this, I've laughed about this as well, but it works, it works. you get 46% less relapses. So this is one or two examples of augmented reality. Another point is gamification with the serious games. This is has also been inferred in the therapy so far. One example comes from New Zealand with the gamification SPARKS, which stands for Smart, Positive, Active, Realistic, X-Factor Thoughts. This is the online side. And what is it all about? The target groups of this are teenagers, male and female. It's a role play in a magical fairy tale world. Characters can be chosen. This is important because we want to have it from males and females. Lots of adventures are waiting and puzzling problems have to be solved. To fight depressive GNATs. GNATs are gloomy, negative automatic thoughts. This is a program for depression. And it contains also exercises for relaxation and has multiple elements of cognitive behavioral therapy in it. And it worked. It worked with teenagers from 16 to 20 years. And they used it in New Zealand. And I would recommend it. As far as I know, it's only possible to get direct access in New Zealand so far, but maybe other states will conquer it. One of the next would be the use of avatars. And the use of avatars might be interesting in medicine. And because you have some information you have to tell daily to a lot of people. And if you do this by an avatar, the effect is as good as if you do this by yourself. The very last part is the therapy in virtual spaces. You can use these glasses and you're in a virtual world, for instance, for social anxiety. You can control the world and get patients in a special surrounding. So, pros and cons of internet psychotherapy are to be discussed. I'm at the very end of my talk at this side. Thank you very much.